Hello, everyone. First of all, I would like to thank the Scientific Committee of the 26th International Congress of Education and Sports and the Northern Greece Physical Education Teachers Association for providing us the opportunity to present to the community our results. My name is Theotokatos. I am a PhD candidate in the School of Physical Education and Sports Science, and I am here to present to you our study entitled Functioning Assessment of Mental Health Patients in Greece, Application of the WHODAS 2 12-item version. This is a collaborative work between the National Kapodisian University of Athens, the University of West Attica, and the University of Vermont in the United States of America. I would like to declare that this study was a continuation of a pilot project initiated from the Greek Ministry of Labour and Social Solidarity and was funded and supervised by the World Bank and the European Commission. The result of the World Bank's report can be found elsewhere, and they are not in the scope of the respective study. I was personally supported for a certain portion of this work by the Fulbright Foundation in Greece and the Fulbright program. A few words about the International Classification of Functioning, Disability and Health framework from now on as ICF, that was developed from the World Health Organization in 2001. And it's a point of view with respect to the biopsychosocial approach of disability assessment. So we have a health condition, could be a disorder or disease that affects the body functions and the body structure, having an impact on activity and participation of the person. And as you can see, the arrows go both ways. So activity can affect participation or the health condition and vice versa. There are, of course, some contextual factors, for example, environmental. For example, participation to the community could be facilitated by a person, a carer, or a family member, or personal factors with respect to the specific individual characteristics such as social roles, genders, race, etc., etc. So what is functioning and disability according to the ICF? They are both umbrella terms, and it's about perspective. If we talk about the things that the person can do, we talk about functioning. And if we talk about the things that the person cannot do due to barriers or hindrances, restrictions or limitations, we talk about disability. So WHODAS is a questionnaire examining 6 different domains of daily life: cognition, mobility, self-care of the person, interaction with other people, life activities, and participation in the community. There is a long version with 36 items and a short version with 12 items, which is the one that we have been utilizing through our study. So the participants are being called to respond to the following question: in the past 30 days, how much difficulty did you have in? You can see the different items, and they respond from 1, no difficulty at all, to total unable to do the respective activity. A few words about disability assessment system in Greece. There is a 3-member medical committee who assess the history of the patients, of the applicants, and they have access to the hospital admissions, surgeries, lab exams, other tests, and they attribute a diagnosis, an ICD-10, based on the unified table for determination of disability rate. So they attribute a disability percentage that is actually a Barema disability scale. Historically, Barema scales have been used to attribute disability percentages to war survivors or work-related accidents. For example, if you have an amputated finger, people get 5% of disability percentage, or if we have the amputation of the lower extremity, we have 50% of disability. So this predetermined disability percentage is highly debated. It's objective, and it's, of course, not good for using it in cross-country comparisons. What about validity and reliability evidence of the Greek 12-item version of WHODAS 2? There are some studies, 3 different studies to the best of our knowledge. Nevertheless, they have been conducted to limited populations, ranging from 100 people approximately up to 200 people. So the purpose of the respective study was to examine the psychometric properties of the WHODAS 12-item version to patients with mental health and behavioral disorders that had applied for welfare benefits in Greece, and examined the differences between the biopsychosocial and biomedical approach of disability assessment. We ran factor analysis in order to examine the construct validity, and for the convergent validity, we assessed through the correlation between Barema disability percentage and the doctor's Barema-Score, and the WHODAS score, and of course the correlation between the number of morbidities and WHODAS score. The Cronbach alpha examined the internal consistency of the questionnaire, and of course we assessed the results for floor and ceiling effects. Overall, we had data from 10,163 individuals that had applied for welfare benefits. And for the purposes of this presentation, we have used results from 2,748 adult individuals with mental health disorders. A few of the demographics, as you can see, the majority of the participants were male, and the participants declared that they were unemployed due to health reasons. The majority replied themselves, and only 21% had their carer or family member to reply for them. The mean age was approximately 47 years of age, and the mean WHODAS score was 58% and 65% approximately for the Barema-Score. Two factors were extracted. The one was named psychosocial, since we have life activities, participation, cognition, and getting along grouped together, and the physical or motor factor, because self-care and mobility items were grouped together. The psychosocial explained almost 50% of the total variance, and the physical explained 10% of the total variance approximately. Pearson SAR between WHODAS score and the medical committee score was significant, nevertheless was extremely low. Pearson SAR between the WHODAS score and the multimorbidity was significant again, but also as well. A few words about these results. As you can see, there's a big discrepancy between the disability score from the doctors, the biomedical approach, and the biopsychosocial approach of the WHODAS. Here you can see that from WHODAS scores, we can get all spectrum of disability, from not disabled at all up to 100% disabled. So we have a normal curve. This is not the case for the Barema-Score percentages. As you can see, we don't have the normal curve, and 67 is a threshold according to the legislation in the Greek state, where you can be entitled to have health services or benefits. And approximately 60% of the participants were attributed with 67% or 68%. Here are the outliers. There are no outliers for the WHODAS disability score. Nevertheless, you can see the figure with respect to the outliers of the Barema disability score. Continuing with the results, the Cronbach alpha was excellent, above 0.9, and no floor or ceiling effects were found. Concluding, WHODAS Greek version 12 items seems to be a brief, valid, and reliable measure of mental health patients' assessment for use in health and welfare services research. And of course, subjective appraisal of disability by the patients and limitations that they are facing can contribute to tailor-made rehabilitation, improve patients' community participation, and overall functioning. Crucial information with respect to the affected domains of life activities can be provided with ICF-based tools, providing a holistic assessment. Some of the bibliography that was used, and a recommendation, if you like, I think you should all see the Greek camp. It's a documentary with respect to camps of disabled people that ignited in late 20th century the human rights and the rights of disabled people. Enjoy, and thank you so much.